Somebody reminded me that you might want the answers to the quiz. But I bet everybody's probably got 100. You probably figured out the method to my madness on that. But autonomous will 1 is G, 2 is D, 3 is H, 4 E, 5 A, 6 C, 7 B, 8 I, 9 F. And if you didn't get it quite right, go ahead and change your answers, and everybody's got 100. Am I correct? Yes. Okay, good. That's kind of a fun little thing to do. All right, let's come back to the discussion about ethics. And some of you are, all of you are specialists, and you are all generalists. And you are generalists in the sense that you have all of the skills that a rehabilitation counselor has. You know about rehabilitation counseling, you know about counseling techniques, and you know about the world of work. Those are things that you have acquired through your training as rehabilitation counselors. That sound familiar? Okay. Then, as a rehabilitation counselor, you have stuff that you have to do every day. This is the ethics of the mundane. You have to follow a process. Right? The same process with every person that comes in. You have to follow that process. You can get creative about what you do within different parts of that process, but you still have to follow the process. If you don't, what happens? What'd you say? I missed it. Oh.
You can get behind.
Yeah. All kind of turbulence happens. All kind of problems happen. It messes up the system when you don't follow the process. And you may have a discussion with your QA people, quality assurance people, or you may have a discussion with your supervisor, and they're going to help you to make sure that you stay in the rut of the process. They don't want people out there creating new roads and new pathways. They want people following the process. Following the process gets boring. Everybody does documentation. Russ invited me to Pennsylvania last year, and one of the things we talked about was SOAP notes. And that's a way of doing a particular way of case recording that you follow. There's different types of prescribed ways. In Pennsylvania, they have adopted SOAP notes, and all counselors are expected to have their recordings following that particular method of case documentation. That's part of the QA. Documentation not only is something that you have to do now, but you have to follow a prescribed order. I'm not going to get into SOAP. I want everybody to stay awake. So those are kinds of things we have to do. Continuing education, those can be fun things to do like this, hopefully. But also, when you are here, what's happening back in your office? Chaos. It's funny how paper is an inanimate object, but that stuff grows like unchecked amoeba when you're gone. Am I right? All the stuff that comes back. I used to hate to come back because I get a stack of pink slips. I don't get stacks of pink slips anymore. I'm teaching an online course this semester. I get about 50 emails a day. And if I don't check my email every day, then I'll have 100, 150, 200, 250 emails by the end of the week. And it just stacks up. You've got to keep that stuff going. But you've got documentation that you have to do. Your continuing education that you have to do, which can create problems. Paperwork, not just documentation, but all the other forms you fill out. Somebody at ECU had a great idea. Before I can travel, I have to do a pre-travel checklist. that I use to fill out my travel request form. Then when I get back, I have to fill out my pre-travel request for money form before I submit my final travel voucher. So I fill out 4 forms for each trip. It was 2, but somebody messed up, now it's 4. And only pure bureaucrats can understand the logic behind that. So you've got that kind of paperwork to deal with. In addition to your documentation about the services that you provide, you've got production. Who's a VR counselor? What's your quota, your goal, production?
Oh, well, 20 successful rehabs and 40 plans a year.
20, okay, 20 successful closures and 40 plans. Anybody else want to volunteer? Yeah. 45?
5 and 4.
54.
Sorry, 54.
54 closures? And how many plans? Don't count
I
plans.
don't know.
Some states don't count plans.
I
Okay.
made a mistake. It's 24. Successful. My colleagues here pointed out to me.
Okay. Now you have opportunity to clear the record.
Yes.
Okay, what is it?
24 rehabs. Successful.
So 20. Okay. In the vernacular of rehab, you got 24 26s, right?
Yes.
Okay. We got 24, we got 54.
Washington State's not doing that anymore, actually. Now we're talking about 90% of our plans should be done in 60 days. And it should be about, so it's all about percentages, 90% of our caseload. And we're following WIOA
Okay.
for that.
Those are what's known as process goals. When you've got to complete so much along the process, it's not a production goal, it's a process goal. So many, you've got to meet so much on certain timelines and things like that. In Washington State.
That's what we do in Washington State is process goals.
Anybody else? What is it in Pennsylvania?
Our successful rehab rate does depend on how many years of experience we've had. We just set a new goal of 13. If you have like 30 years of experience, then you have to have 26s.
26, 30, 26. 26, 26s.
So 26 status 26.
26, 26s. Okay. Okay. So you've got production to deal with. You've got all those numbers. And experienced counselors, what they'll do is they'll juggle it. If you've already got your 26 and it's June 1st and you got 2 or 3 more to close, you wait till July 1st. Is that ethical? But that's where the ethics of the mundane come in. And then, of course, we've got committees and meetings we have to go to. Many universities, including ECU, has a committee of committees. And that's the committee that monitors all the other committees that run the university. It's so big. So y'all on committees? There's some RIP committees is real popular. Reduction in paperwork. It's called different things. RIP committees are popular. But you got those things. All of those are mundane. And each one of them, when you are practicing in the mundane, it's very easy to make mistakes because it's very repetitive. And if you do something that is repetitive, it's easy to overlook something or take a shortcut and not get it done. I have a friend who's an airline pilot, and he tells the story of the first day he was to fly solo, that he went out there and he was with his flight instructor, and they checked off all the boxes and everything, and did his pre-flight check and got it all right. Went and did his solo, and he came back and he did fine. And he wanted to fly again the next day to start building his hours. And he got up there and he says, "I'm ready to go." And the instructor goes, "No, we've got the pre-flight check." And he says, "Well, we did that yesterday." And he says, "No, you do that every time. Every time. because you can't afford to make a mistake. So we're not quite at that level, but we do things on the everyday. Then as a rehabilitation counselor for the deaf, you are a generalist and a specialist. You still know counseling, but specialty counseling for people who are deaf. Certain techniques work better with people who are deaf. You also have to know about the language, you know about the culture, and know how to read an audiogram and understand the different etiology of deafness. You have to know all of that kind of stuff. So for deaf professionals, you have potential problems of confidentiality, boundaries, and multiple relationships are three areas where you can get yourself into trouble. Now, as I go through these, please, your input is helpful, and your experiences that you've had can add to this. Because as we go into this next section, you keep these in mind: confidentiality, boundaries, and multiple relationships. I need confidentiality. You're going to keep your promises. Boundaries is that space between you and the client. We have a big problem with that in deafness. Can anybody give me an example of that? What's a boundary issue that comes up in deafness all the time? Social interaction. Social interaction. What do you mean by social interaction?
Outside of the office, you'll probably see the same people.
So if you live in a town, I live in Winterville, North Carolina, 9,000 people. And if I see somebody there, chances are I'm going to run into them in the Piggly Wiggly. You know? Piggly Wiggly is a grocery chain, for those of you not familiar. And chances are I'm going to see them there. And I may see them at the gym I go to or places like that. So you have to be careful of that social boundary. And then they may go to the same church as I do, and all those different types of boundaries that you have. And then multiple relationships. Have any of you in your capacity of counselor ever interpreted a phone call for a client? For those of you who are hearing counselors? Okay, then you've just entered into a multiple relationship. So you've got those things to look at. So let's look at some risk and liability of being a counselor. What I'm going to do now for the rest of today is to look at counselor risk control, and it's a risk control self-assessment checklist. And it's downloadable. If you need, I think I've got the site in here. If I don't, let me know about it. It's put out by the American Counseling Association Insurance Trust, and they're the owners of the Healthcare Providers Service Organization, HPSO. And HPSO is the primary insurance organization for counselors. If you feel like you would like to have, I'm not doing an advertisement for them, I just find a lot of, especially state counselors, that aren't familiar with this. If you feel like you would like to have liability insurance, this is where you want to go. I told you before, I have a private practice. I have insurance through them. Yes?
It's also less expensive.
Yes, it is. It's very inexpensive. If you join the American Counseling Association, I think you get 10% off. So you have to decide if you want to do that. But it's relative. It's about $200 a year, maybe a little bit less than that. I can't remember. And they have currently 74,000 policies with counselors. So anyway, we'll look at their risk assessment checklist and some of the things that they do. When they were developing that risk assessment checklist, they conducted a big study of claims. In other words, what did counselors do to get themselves into trouble that cost HPSO money to pay to get them out of trouble? How much do they have to pay to settle? And those kinds of things. So by analyzing where they've had cases, then they developed a checklist to help you to stay out of trouble. So any of you, particularly if you're in private practice, this is something you might want to look at. And sometimes state employees will go, well, I'm not liable for that. Yes, you are. If you are negligent, then you're liable. There's something called sovereign immunity, which means they can't sue you as a state employee. So if you were in the diligence of doing the due diligence of your performance of your duties, You can't be sued as a state employee. But if the opposing counsel can prove that you were negligent in the performance of those duties, then your personal assets can be attached. So it's something you might want to look at and think about. What they used here when they were conducting the study, it was claims that were closed between 2003 2012, and it's a study of over 1,000 different cases where HPSO had to pay out money, and included 12 different counseling professions. Of concern to us are the career and counselors and rehabilitation counselors. So those are the ones that they're included in this particular study. Here's some of the things they found out. These are some risk factors. 50% of the counselors that were sued worked in an office setting. Most of you work in an office setting, am I correct? It's a risk factor. 66% of the claims involved face-to-face counseling. That sound familiar? Meet that criteria? Any of you? Okay. 92% of the claimants were adults. And we in rehab mostly work with adults. And the clients sought counseling, these are the reasons they came in for counseling, was marital discord, family discord, depression, and alcohol abuse. So they're not coming to see us for those. Chances are they've had that and they're in remission, or the problem's been resolved, and now they're coming to us to help them to seek employment. And they paid out $16 million in claims over that amount of time. And of those, professional liability with indemnity, with fault, there were 63 cases that they did that. Here's the allegations. This still surprises me of all things as a counselor educator. The number one allegation that counselors got into trouble with was inappropriate sexual or romantic relationships with the client's spouse, partner, or family member. And what is beat into you your entire graduate program? Don't have sex with your clients. But these are counselors, these are CRCs and LPCs, and the number one allegation is inappropriate sexual, romantic relationships with the client's spouse, partner, or other family member. The number two is failure to practice within boundaries of competence. And where that usually falls, where most people think that usually falls, is you're working with some like mental health and you don't have training in that particular area that the client presents in, or things like that, or that you're working with different groups. And where this usually falls is people that are working with children that aren't trained to work with children. Now, isn't there something called transition? Okay, we got transition. Are any of the clients on the caseload in transition under 18? How many of you were trained, you don't have to show of hands, how many of you were trained to work with minors and the system in place to protect minors? So if you haven't had training in how to work with minors and the system in place to protect minors and the rights of minors, minors are what's considered a protected class. And if you provide services to a minor, there's certain things that you have to do. And parents have say in things that they can do. And so if you haven't had training in that, then you're practicing beyond the scope or boundary of your practice. And that would be grounds for a suit. And then the third one, which just blows me away, is improper sharing of confidential information without client consent or legal justification. In your graduate programs, don't have sex with your clients, and confidentiality. How many times did you hear that in courses? I hope almost every course you had. Am I right? So what do these counselors do when they get out there? They have sex with their clients and they tell about it. You know, and they talk about stuff they should. That just blows my mind as to how that happens. And I'm sure if we could look at individual cases that we could understand that. In North Carolina, if an LPC counselor is suspended or loses his or her license, I can go on to the LPC website and they're listed by name with allegation and finding. And I can study that if I so choose to do that. Here's my sovereign immunity slide. You are protected as a state employee, but at the same time, here's what happens. I don't think there's any state, there may be, but most states do not require a CRC to be eligible for employment with the state. Am I correct? But if you practice as a rehabilitation counselor, Georgia requires?
Georgia does.
Okay. Georgia requires? That's one. There's probably a couple others. Let's just say most states don't require that. And if you report that you are a rehabilitation counselor, you are held accountable to follow the CRCC Code of Ethics. If you were called into court, the questions would go something like, Mr. Smith, what is your job title? I'm a rehabilitation counselor. Are you a certified rehabilitation counselor? No. Are you aware of a certified rehabilitation counselor? Yes. Are you aware of the Code of Ethics of a rehabilitation counselor? Yes. And then that line of reasoning will set up to show that you need to follow the Code of Ethics of a rehabilitation counselor. You're held accountable to that code. I'm not trying to scare you. I'm just trying to give you facts about this. So let's look at the counselor risk control self-assessment checklist. Let's talk about this for a little bit. These are the different areas. And the clinical specialty area, I have edited this down because I didn't want to keep us here till 7 o'clock tonight. And we may not get through the whole list today. But the clinical specialty area has 7. The scope of practice and services has 6 different areas to check. Assessment 5, diagnosis 14, treatment and care 14, and competency 6. So I've got some of these, and we'll talk about we'll conduct a little mini risk assessment for you as counselors here. First is clinical specialty, and that means that you have advanced training in a particular area. So if you're a rehabilitation counselor, especially rehabilitation counselor for the deaf, you've had advanced training as a generalist rehab counselor and more advanced training as a specialist in deafness. You're deeply qualified. So this applies to you. Do you work in an area that is consistent with my licensure, specialty, certification, training, and experience? Yeah? Everybody's on the same page on that one? You feel good about that? Because they paid out about $15,000 on a case where somebody didn't do that. Or HPSO did. Okay, let's go to another one. I know that my competencies, including experience, training, education, and skills, are consistent with the needs of clients on my caseload. So everybody you work with is deaf. Is that correct? They're all deaf. That's it. Audiologically deaf.
And hard of hearing.
And hard of hearing. Oh, okay. So now you've got people who are deaf and people who are hard of hearing.
And people with speech impairments.
And people with speech impairment. You work with general caseload? Sometimes you work with a general caseload. So that just opens it up to a whole bunch of disabilities. Let's just keep it on deaf and hard of hearing. We'll just keep it on that. And so the people that come to you are just deaf or just hard of hearing. That's it. No. Deaf plus a whole list?
They could have other disabilities.
Deaf with other disabilities. Oh, okay. So if you work with somebody who's deaf, all these other disabilities, what's one of them?
Autism.
Autism? Deaf plus autism. Oh, that's great. How do they get diagnosed?
A psychologist.
Psychologist. And that psychologist is skilled in deafness and sign language and knows all about deaf culture and deaf children.
Yes.
Okay, so you've got a good diagnosis on autism. What training have you had in autism?
A workshop.
One workshop?
15.
15, okay. You'd probably start passing the test. Let me pick another disability. I'll pick on somebody else. Who else has got a deaf plus caseload? Yes. Cerebral palsy. Persons with cerebral palsy. So deafness and cerebral palsy. How many workshops have you had on cerebral palsy?
5.
5. Okay, great. You two are doing exactly what you need to do. If you are practicing within your boundaries of competence, you know deafness, you're learning about autism, people with autism, you're learning about people with cerebral palsy, and so that's safely within your scope of practice. There's going to come a point in time where one of those deaf, that plus is going to be you don't know anything about. Yeah? Are all of your clients born in America? And English is their first language, or ASL is their first language? Oh, we got all that cultural stuff to come in too. So, maybe somebody who's deaf, autism, parents are from Bosnia. So you've got all those kinds of things. How do you find out about all that stuff? How do you say that you are competent? How can you declare that you are competent in order to provide that service? You two are excellent examples of going to workshops. That's great. That's what you need to do. However, you can be blindsided if they don't have that. Yes?
I took one workshop on deaf transgendered people, but we don't have enough training on that.
Yeah. How do you find training? I didn't even know there was training on deafness and transgender. I hadn't heard of that. That's a good thing. Not that I hadn't heard of it. It's a good thing that training's available. Yeah, but one workshop on. So how do we acquire that? We go to workshops, and you have to be aware of what your competencies are. Yes.
Where I can see that is challenging is I will have clients that have 3, 4, 5 disabilities. They're all documented. And so are you suggesting that I need to make sure that I have had workshops in each of those disabilities in order to make sure I'm competent in order to help them?
Okay. In a perfect world, let me see if I can rephrase you. You have clients that present with several disabilities, 4 or 5 different documented disabilities. In a perfect world, yes, you need to go to workshop for each one of those. We don't have a perfect world. You can't spend the next 2 years going to workshops to learn about each one of those. You have to look at the functional capacities and try as best you can to understand how those functional capacities can be used in a work setting. And grab that knowledge, consultation, working with other people. If the individual is transgendered, you talk to the lady back there. If the individual has cerebral palsy, talk to Jared. Talk to the lady over here if it's autism. You have to do those types of things. Ideally, yes.
Sometimes you have a client who has a disability you're not familiar with, like charge syndrome. That came up for me, and I had never even heard of it. I had no training on it, and so I had to spend a lot of my time doing as much reading as I could and research on it that I could when that situation came up. So sometimes it's unpredictable and you can't prepare in advance.
Right, you can't. What you do is if you get yourself in, remember this is from a liability perspective. And so you have to say exactly what you did. This is how I prepared, this is how I gathered the information. And the more experience you've had assimilating that type of information, then the better case you make that, yes, this is within my area of competency, this is within my area of practice. Are you passing yourself off as an expert in charge syndrome? No. What you're doing is you're saying, I understand some of the implications of charge syndrome plus deafness and how those two may interact in the employment situation, and we're going to go forth with that. Am I right? Am I putting words in your mouth? Okay. Okay. Good. Thanks. And so, yes.
My agency is RHA. It's a statewide agency that contracts with to provide services. And we only have one professional who signs. And so if a client wants direct communication in American Sign Language, we only have one person that's able to do that in the entire agency. So I'm not an expert in substance abuse. But myself and another counselor in the area are the only ones who sign. And so even though we don't have expertise in that particular field of substance abuse, we end up collaborating with and consulting with those who are experts in it because we can provide the counseling and the services in the language that the client needs. And so some of it is going back to that communicating with the client to let them know we have experts in that field or we have someone who can communicate in your language. So it's up to you which way you'd like to go.
It's a great example of the need for cooperation or collaboration, depending upon the definition from Heather this morning, one or the other, that you're going to need to have folks that you can communicate with. Find out about charge syndrome. Working with people with substance use issues when that's not what you've been trained to do, and learn and provide the best service that you can. You have to be careful because you always want to provide the best service you can, but we have to go back to which one of the principles was it we operate in? Most of our work is in. Remember? Use your cheat sheet. It's okay. Look.
Beneficence?
No, it's non-maleficence. You want to do no harm. You want to do no harm. So even if you think you're doing good, you want to make sure, that you're doing no harm. That you're competent to do what you're doing. So yeah.
Another example is I'm not a mental health counselor, but I work with people who have mental difficulties. And so I work with an agency that does provide those services. So there's a lot of referral going back and forth. I'm with employment, they're with mental health, and so that mirrors.
Okay. So if I heard you right, what you're saying is you work in an agency, primarily it sounds like a placement-oriented agency, and you have some clients that have mental health issues. And you work with the agency that's working with them on the mental health issues. You kind of work on the employment side, and you cooperate back and forth. That's a great way to work. And the more you work with that population, interact with them, the more you learn from those staffings and meetings and that informal learning that we do and understanding and appreciation. I've had the opportunity to work with several psychiatrists over the years, and it's amazing what I can learn just sitting in the staffing with that psychiatrist and his or her view of the client and what's going on. Very, very interesting. So you learn those kinds of things. We got a lot more of these folks. If we get done, great. If we don't get to them all, that's great too. I understand the specific risks of caring for clients within my clinical specialty. So do you know, that kind of says you know what you're doing as a counselor for the deaf? You know what you're doing there. And that there are risks associated with serving them. What would be a risk of working with people that are deaf or hard of hearing? Russ?
One big risk is miscommunication. Sometimes they'll use inaccurate vocabulary, and you can really misunderstand what they're trying to say.
So at the most basic counselor-client relationship level, you can have issues with communication based on the communication skills of the counselor and the communication skills of the client. And is the counselor able to adapt? Remember hiring a counselor one time, great counselor, phenomenal counselor, graduate of Gallaudet's counseling program, great communicator, came into the community and was working with people from the community that graduated from a so-so kind of quasi-okay special ed program. Students there, their sign language. And it took her a while to adjust so that their communication, they could communicate. Because if you come in all fast with all the finger spelling, it's difficult. So that's an example of one of the risks. I decline an assignment if my competencies are not consistent with client needs. Has anybody ever turned down working with someone? Want to share about that? When was there a time that you turned down somebody because you felt inadequate to work with that person? What type of individual would you turn down because you would feel inadequate to work with that person? Who's had a referral on somebody who's totally deaf, totally blind? You accept the referral?
I did accept a client like that who was completely blind and who did not use Braille. And it was tough, so I worked a lot with the interpreter to make sure that the communication was clear. So I depended quite a bit on the interpreter to make sure that we were getting the message across, that the right message was being understood. It was tough. It wasn't always clear. And I did reach out to the department that serve, the Department of Serving Blindness too.
Okay. So you felt comfortable from a deafness perspective to go ahead and accept that individual and work with that individual, at the same time seeking that, like we were talking about, seeking that advice and expertise and consultation from Services for the Blind. That's a great way to handle that kind of situation. But there's going to come a time in everybody's career when you're going to run into someone that you're not comfortable doing, not comfortable seeing, because of your lack of skills. And you need to recognize your own lack of skills, because nobody's got everything. We like to think we're wonderful and we can do all these things, but you've got skills, and as soon as you bite off more than you can chew, as soon as you take somebody that you're not prepared to help, and you don't know what you're doing, you have committed an ethical violation, and you probably have risked your liability as well. So you need to do that. This is an area where most of the payments were for adult services, not for children's services. Clinical specialty. I ensure that my competencies and experience are appropriate before accepting an assignment to cover for another practitioner. How many of you have ever been in an office where there's a counselor vacancy? The New Bern, North Carolina office. I don't know what it is about that office, but they had 3 counselors leave, and 2 of them got pregnant and were on maternity leave, and they only have 7 positions. I could be a little bit wrong on that. But, so the counselors that were left had to cover for all those other counselors that were there. Transition caseload, different caseloads. How would you feel about covering for a counselor on another caseload? If you're deaf, I'll talk just for a moment to the people in here who are deaf and primarily use sign language. How comfortable would you be taking over for a hearing counselor with a hearing caseload?
I feel comfortable.
Feel comfortable? Is that within your area of competency? As an advocate for people who are deaf, I'm kind of going against my own beliefs here, but I want to make a point that you need to be, if you're going to volunteer to cover for another counselor, you need to have the competencies in order to cover that position. I see people doing this. Russ?
Yeah, I think there could be an ethical conflict, at least in Pennsylvania. We have a lot of people in the system there. And sometimes, and especially if we have a new counselor, sometimes the management kind of forces them to take on a caseload that's overtime. And that doesn't always fit the new counselor's experience or expertise. So I don't know really what a resolution would be for that.
Do you not serve people? Do you say, wait, we'll get the position filled and then come back and we'll provide services? Do you have somebody cover? How do you have to manage that situation? It becomes a management issue. That's a management issue. The counselor, the personal issue is, are you comfortable assuming role for another counselor? How is that decided? Yes, Jared?
Yeah, you have to be honest. First, the counselor has to decide if they have enough capacity, if they may already be maxed out with their caseload. So that's even the first step of consideration.
Yeah. Now, what about your caseload? Yes.
Yeah, I think it's very interesting because the state has their expectations, expecting that I would accept whatever client comes my way. But at the same time, I also need to be following the code of ethics, whether I'm certified or not, like you said. So I'm expected to follow the code of ethics, but then I have expectations from the state as well to take on that risk. So it seems like, I have no say in anything. And it's a little bit of, do it or be fired. It's interesting to see the state expectations of us and how they're sometimes in conflict with what the code of ethics that we're supposed to be following.
Most of the time, folks are reasonable. I believe that most folks are reasonable, even state bureaucrats. They can be reasonable. And if you explain your concerns and sit down and communicate, you can usually work out some kind of compromise situation where the clients that you would consider most at risk due to your own areas of deficiency, that could be taken care of because you do have proficiency. Remember I started off, I said you're all generalists and then you specialized? So you have the generalist ability and you can do some of that. So part of it has to do with communication, use of interpreters, how the other clients are going to feel about that. Here I've got this relationship with this counselor. This counselor's on maternity leave. Gone. Okay. If all you need is for me to reauthorize your tuition for next semester's college, that's easy. But if what you have is a problem on the job where you need a job coach to come in, set up some intervention, blah, 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 all those kinds of things, then it becomes more complicated. Always get somebody in the boat with you, particularly your supervisor. You always want that to happen. Clinical specialty. I am provided with a request and obtain orientation whenever I work in a new or different client setting. Who does job placement? You ask for an orientation of the site? Yeah, okay. Then you're practicing within a good clinical orientation of what we do. Anybody else practice off-site? You get an orientation to where things are and do all those kinds of things? You're doing well. That's what you're supposed to do. I obtain continuing education and training is needed to maintain competencies in my specialty. Ta-da! You're here. That tells me that you do it. These are recommendations for clinical specialty, things to worry about in risk, not worry, but to be concerned about in risk. Proactively obtain your education, which you're doing now. and work in settings aligned with your clinical specialty. Sounds like most of you are probably doing okay in this area. Let's go to scope of practice and services. And I've got a few of those that I pulled out. How many of you read your State Practice Act at least once a year? How many of you have read your State Practice Act? Did you know you have a State Practice Act that authorizes you to practice as counselors? That's something you might want to think about doing that. They paid out $136,000 in claims because they proved that counselors didn't know their legal ability to practice within the state. How many of you comply with the requirements of the state regarding regulatory bodies such as Department of Health or Department of Mental Health? Yes.
At least once a year we do because the laws change. You need to know what they've added or what they've taken out.
Yeah. And I'm from North Carolina. I'll just own it. We're the bathroom state. Everybody knows about our bathroom bill. And that legislature, they are prone to change things, and it's a good idea to keep up with them. Yeah, thank you for bringing that up. I collaborate with or am supervised by a counselor or physician as defined by state laws and regulations and required to meet the needs of the caseload. Does your supervisor, remember there's two kinds of supervision. There's administrative supervision. Do you show up to work on time? Clinical supervision. How am I handling and monitoring my caseload? Most supervisors know how to do the administrative. Get that out of the way. Does your supervisor have knowledge about what you're doing to give you feedback on your performance as a counselor? Room got real quiet, real quick. Think about your supervisor. Yeah, some of you do. There's a Dr. Chad Betters at Winston-Salem State, and I did a study a couple of years ago about vocational evaluators that work for state agencies, and we found that a significant percentage of the supervisors of vocational evaluators didn't know anything about vocational evaluation. They just provided administrative supervision, not clinical supervision. Can you go to your supervisor and say, I'm having a problem with this case for whatever reason it is, and have faith that you're going to get good feedback on what to do, good feedback on how you're handling the case? If you do, consider yourself lucky, because most counselors for the deaf don't have that. Yes?
In my state, most of the supervisors are very by the book. I think it might depend on your state. And in some states, supervisors are just one notch below the state level. And they might have been a counselor previously, and once they become a supervisor, they become a different person.
Well, you do become a different person because you assume a different role. But what you're describing is that administrative supervision. Are you dotting your I's and crossing your T's? And most supervisors will do that. What I'm talking about is if you're having problems with a client and you're saying, I'm just not connecting with this client, I just don't know what to do. I feel really stuck. I've tried this, and this, and nothing is working, and we're not even getting basic reports. It's just not working for us. I'm trying to figure out what to do. That's clinical supervision. And can you go to your supervisor or a physician or a senior counselor or someone and present that case and get feedback? Well, have you tried this? Have you tried this? I don't know if that was a really good approach to take with this client given her background and those kinds of things. And so within your scope of practice and service, you need to be getting feedback on the specific service you're providing. In addition to, did you show up to work on time? Are you following the right documentation procedure and those kinds of things? Got both of those. Yes?
So I'm fortunate to be really, I have great supervisors right now, but when you're in a situation where you don't, and it's still your responsibility to follow these kind of ethics, and they're
Okay, then the question was, if you are in a situation where your supervisor perhaps isn't familiar with what you're doing, can't really give you that information, and you're in an environment where you're kind of by yourself, then that's where professional organizations like this come in. Now, you can't go in and say, I'm working with Susie Smith over here, blah, 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 but you can say, I've got this case, blah, blah, what do you think about it? You can also seek out senior counselors, either by rank or time in service, somebody that you trust, and have peer supervision in the area of clinical. Sometimes some agencies will recognize that, sometimes it's informal, but you seek that type of supervision, maybe a mentor, and you seek that kind of supervision so that you can then receive that input. Hey, I tried this, it's just not working. Well, have you thought about this? Okay, I'll try that. And then they come back later. How'd that work? Well, it worked pretty good. Things are rocking, Then you have that kind of relationship with somebody. Hopefully, in the best of all worlds, your supervisor can provide that. In some settings, there's a mental health facility, substance abuse treatment facility, not just down the street from ECU. They have a clinical supervisor and an administrative supervisor. And a lot of hospital, medical model places do that. But you need to have that kind of supervision. Try another one? Sure? I don't know if Jared's going to leave this in or not. One of the things I do when I'm up here is I count uvulas. You know what your uvula is? That little hangy down thing in the back of your throat. In cartoons, they hit it like this and they use it as a punching bag. And so I count uvulas. And when I see 3 uvulas within 1 minute, that means people are yawning. And I just saw 4 uvulas. So I think it's time for a short break. Would that be okay? I don't know if the cookies and tea are still there, but at least you can stand up, walk around, and have one, what did the interpreter call it? A bio break. Have a bio break. And we'll come back in 7 minutes. How's that? I'll start back in 7 minutes.